QD Clinic here, brought to you by Room Now Live, changing minds in practice in downtown Fort Worth on March 22. Be there, live or online. Today's case is the power of patient choice. Just recently saw a 25-year-old young gal who's had inflammatory arthritis in both knees with enthesitis, with an elevated CRP and a low titer ANA. And I'm calling her a pauciarticular JIA or a B27 positive peripheral spondyloarthritis. Doesn't seem to matter. She's been tried with non-steroidal. She's had her joints injected. She needed to move up to a DMARD. And the question is, what DMARD did I want to use? I wanted to use methotrexate. I gave her a range of possibilities, did not offer her a biologic at the outset. I gave her a number of different DMARDs to choose from. And she took a prescription home and then called back and said, she talked it over with her husband. They don't really want to be on methotrexate. When I gave them the list of side effects, they preferred the side effects associated with hydroxychloroquine. And so that's what she started. Again, I didn't think that was a very good move because I thought she had enough inflammation that I wanted something that was going to work maybe more completely, maybe more quickly. But nonetheless, I always like to go with what patients want to do, especially if I was 100% certain, I try to talk her out of it. Can't be 100% certain. So we let her use hydroxychloroquine, and she comes back after 8 weeks, and lo and behold, she has nothing. No enthesitis, no swollen knees, and these were swollen knees with fairly good sized effusions and warmth. Totally gone. She's now back to running. She feels good. Oh, and by the way, she's pregnant. So it's probably a good thing. She didn't expect the pregnancy. She's on hydroxychloroquine. She's going to continue it. And then we'll see how she's doing as we get into the middle trimester. I'll see her back and we'll make a decision about hydroxychloroquine. Told her there's no rush to stop that. But I think what's remarkable about this case is the idea of patient choice. I think all studies should involve an additional arm. Let's say you're doing a 3-arm study. Drug A versus drug B versus placebo. I'd add a 4th arm. It would be drug A versus drug B versus placebo versus patient choice. Because in my experience, and there's some literature to support this, when the patient chooses, they actually have better buy-in, more compliance, they're motivated to get better. It seems like that they have an active participation in their own improvement. It works out incredibly well. I recently saw a patient who was just a horrible case of rheumatoid arthritis. I mean, just god-awful, miserable. And she had previously been treated with Actemra, tocilizumab, and a combination of a bunch of drugs did nothing to her. And she came back and we went over again this would have been like her 35th choice as far as therapy. I mean, I'm at the end of the rope, really. And I offer her Kevzara, sarilumab, the newer IL-6 inhibitor. She came back in 2 months and nothing. She had like 15 swollen joints, incredible disability, all disappeared. But she chose, that's what she wanted to do. And I think that her buy-in, many of her other choices I've given her in the past were given as sort of like, this is last-ditch effort. I gave her a number of different choices, and that's the one that she wanted to do, and it's amazing. So it goes to what we talked about the other day. You can switch within classes, but again, the most important switch in that patient and this first patient I talked about is giving the patient their choice. They actually stack the deck in favor of a response, in my opinion. Tell me what you think.